see in outpatient clinics, have body mass indexes in the 25 to 30 range. So most people with atrial fibrillation are overweight, and some of them are significantly overweight. And what's striking about this group is they're all underweight. We'd been telling them to eat more if they were coming to our clinics. They've got very slim waists. I don't know what 76 centimetres is in inches, but it's you do it for us, divide it by 2.5 and you'll tell us what inch waist. But it's going to be a slim population, and they've got immaculate blood pressure control, 120 over 70, that's fantastic. It's very good. And yeah, there were some cases of hypertension, 24% of them. There's a few patients of people who had this coronary artery disease. But you know, these risk factors that we look at, which we know contribute to atrial fibrillation, they're very, very well controlled. And this starts to play into the idea that maybe there's more to the management of atrial fibrillation than just controlling the rhythm. Maybe we need to focus also on the control of these other so-called cardiovascular risk factors. And I want to share some data with you about this. We should stop moving those tables.
30 inches.
30-inch waist. 30 inches. That's pretty slim, isn't it? Yeah. I won't ask Anza who's got a 30-inch waist.
A long time ago.
A long time ago, me too. Okay, so if you go to a textbook of cardiology and you open it on the page of AF, and you want to say, what causes AF? Right? You will get a list of things that are associated with this condition. Okay, and they're in no particular order, but perhaps the more common ones at the top. So hypertension. Many people with AF have got hypertension. Many people with AF have got diabetes. Many people with AF are overweight. Many people with AF have had some cardiac disease, like a coronary artery disease in the past. Some of them have valve disease. Some of them have overactive thyroid. When we see a patient with atrial fibrillation, we always check the thyroid function. About once a year it's abnormal, it's overactive, and we treat that and the AF gets better. So this is small print. Alcohol, inflammation, whatever that means, probably means low circulating levels of inflammatory things which make and cause cardiovascular disease. Another thing's not on this list, sleep apnea. So people where their airway obstructs at night, we know that's associated with cardiovascular disease. So almost you could cross out AF there and you could put coronary artery disease and then put that list. You could put hypertension, remove it from this, and that would be the list of things that cause that. So they're all interrelated, these conditions, and they're all promoting cardiac disease, be it coronary disease, high blood pressure, or atrial fibrillation. And I suppose, you know, you're thinking about what's going on, and I said to you, well, maybe in the 18-year-old patient with AF you could cure it. I think that's true. But when you're 80, you've probably got these other factors which are causing the atrial fibrillation to come. They're causing structural changes in the heart, which may be microscopic, but they are persistent, ongoing, and that's why the AF tends to keep coming and going and coming back even if you get rid of it. Now somebody said, what's the best tool for treating AF? Is it novel anticoagulants? Is it burning the atrium with an ablation catheter? If you don't like heat, go cold, freezing it with a cryo balloon. Is it giving lots of drugs? Actually, probably the best way to start with is giving people lots of information about the condition because it helps them understand it and then manage it better. We're worried about it because it can cause stroke and sometimes heart failure, but sometimes it does nothing at all. It doesn't cause any problems. Some people can be completely disabled with it, and others are in the Ashley Centre having a nice Friday morning and they don't even know they've got it. And it goes with inflammation, wear and tear, ageing, but also it can affect very healthy people. Very fit athletes can get it. So it's a funny disease, isn't it? You can't kind of pin it down. It's like a chameleon, it keeps changing. Okay. So I'm going to tell you about two studies where they've tried to look at this question of if you modify these risk factors, can you improve the symptoms, the frequency of atrial fibrillation? And they both come from Adelaide in Australia. And then both of them have been published in highly reputable journals. This has been published in the Journal of the American Medical Association, known as JAMA. And this group did a trial. So if you're reading a piece of literature, paper or something, or you read something in the daily whatever, and you decide, oh, I'd like to look at that in some more detail, and you go onto the internet and you see the paper there, you think, oh, I might have a read of that. Then there's important words in these trials that you need to look at. Things like randomized. That means the people in the study, they got randomly assigned to the different groups. It wasn't picked by the investigator. In other words, it tries to reduce the bias. Okay? So what they wanted to do is see if you did weight reduction and risk factor management, whether you could improve the symptoms and the severity in people with atrial fibrillation. So what they did is they took some people who had paroxysmal atrial fibrillation, that's fibrillation that comes and goes, and they randomized them into two groups. So one group had a very intensive weight loss program. These were overweight people, as you'll see in a minute. This is the intervention group. So this was a special diet, lots of counselling about risk factors. So the aim was to help them lose weight. And the other group, the control group, were just told, just lose some weight, that's it. See you in 6 months, let's see how you're getting on. So control, in other words, just lifestyle, general measures. They evaluate them at 3 months and then follow up the patient to see what the results are. And this just tells you, there's a lot of data in here, but just to tell you how they actually did it, because it might be important if someone's thinking in the audience, maybe I'd like to try this. How was this weight loss done? So this was a very low calorie diet, so between 800 and 1200 calories a day. Now that's a pretty small number of calories. You think a man averaged 2,000 to 2,500 calories a day. So this is a significant reduction in calories. Calories are difficult to judge, aren't they, sometimes? It's hard, you're not sure, but some foods have got lots of these in. Sandwich, cheese and pickle sandwich you might get in by a supermarket or even make yourself at home could well have 400 calories in it. We've got plenty of carbohydrate, lots of protein and fat. So you could see a couple of cheese and pickle sandwiches, you'd be at 800 calories. Yeah, that's a day's worth of calorie. So we're talking about severe calorie restriction. And they do this by giving them one of these things, you've probably seen them advertised, Light and Life. They're like sachet meals. So they've replaced the meals for 2 of the meals with the low-calorie replacement that contains all the vitamins and things. And they're being medically supervised, so that's fine, it's safe to do that. And the 3rd meal, it's low glycemic, it's low carbohydrate. They give them an exercise plan, 20 minutes 3 times a week, up to 45 minutes 3 times a week, so quite aggressive exercise. And then gradually, after the 8 weeks, they phase out that really strict diet and replace it with just a healthy diet and then keep following them up. So good weight loss program, and they maintain their diet activity and their blood pressure diet. The control group, just as I said, got a bit of written information, and read it if you like, and they didn't ask them to monitor their diet and activity. And they measure the AF symptoms. There's a scale, in all these research papers, you need some kind of measure of how symptomatic somebody is. And they've got this scale which goes from about 3 to 30. So if you have 3, you've had 1 episode of AF lasting a few minutes. If you're at 30, you're symptomatic lots and lots of the time. And it measures how frequently you get it, how long it lasts, and how bad you felt when you got it. So it's a way of trying to attach a number to each patient in the study to see whether there's a difference between the 2 groups. Now this is small, but it just gives you an idea of the sort of people who are in this. There's 75 in each group. They're about 60 years old. And when you're looking at a trial and trying to work things out, then you need to make sure that the 2 groups were quite well matched. Because supposing the people who were in one group, let's say, were much older than the other group, well, that could influence the results. So we need to be careful and make sure they're all matched together. Because it's done randomly, they should be. So it should be as many people of X age going to one side as the other. So you see that about half of them were men. Now their waist circumference is 110 centimetres. What did we have before?
76.
76. So they've got 30 centimetres more. Yes, typical 98 kilos, body mass index of 32.8. So these are quite, people who were significantly overweight, and some of them having more alcohol than they should be having, and a lot of people with high blood pressure, diabetes, high cholesterol, previous coronary disease, about 10%, sleep apnea, 90% having sleep apnea. So this is a typical overweight, high blood pressure type of population where you really want to target this. So ideal group to study. So this is what happened to them. So this is the waist circumference, and this is 15 months of treatment. The control group, if you do anything to people, the benefit happens, even in the control group. So if anyone's ever says to you, would you like to be in a clinical trial? Always say yes, because even if you're in the control group, you'll do better than you would have done otherwise. It's called the Hawthorne effect. Has anyone heard of that?
Yeah.
There's some nodding, yeah. It's in the Hawthorne Electric Factory where they came in and changed the light bulbs and told the people they were changing the light bulbs, and we'd seen whether the lighting affects the amount of work you do. And then they didn't actually change the bulb at all, it was exactly the same, but because someone had done something, the people worked faster. So if you observe something, you often can see a change. So you see people do get slightly slimmer, and their body mass index does drop a little bit if you put them in the control group. But if you intervene, as you hope, with your lighter life type diet, then you really can have quite a nice effect. So these people have almost dropped nearly, well, that's between 15 and 20 centimetres off the waist. That's quite significant. And body mass index has dropped. Remember, it was about 32 to start with. So they dropped down by about 5. So they've come nicely, still a bit overweight, but they've done pretty well. They've dropped their weight significantly by this. And it seems to be a nice, gentle, progressive thing. Of course, what you want is what happens over here. Does it do that? Yeah. Or does it go that? Or does it just flatten off? I suspect it probably goes up a bit. I don't know. It depends. All these trials, they're relatively short term because you can't do a trial over 10 years, you want data. And this is what happened to their AF. So their symptom burden, this is your control group again, you can see the symptom burden decreased and the severity decreased. It actually got better. The AF wasn't there as much, and when it was there, it wasn't as bad.
Sorry, did you say that was paroxysmal?
Paroxysmal. So this is a good advert for saying that a bit of weight loss seems to have a beneficial effect, not only on your weight, but also on things like your atrial fibrillation severity and frequency. And actually, if you look at the paper in detail, I'm not sure I've got it on the next slide. I have got that, but I haven't got the rest of the data shows that the blood pressure improved, that the blood sugars got better, the markers of inflammation improved, all the parameters got better, everything got better for those patients. So it's really worthwhile, and that was a simple, non-drug intervention that anyone could do. Not particularly expensive in terms of the therapy, although probably quite expensive in terms of the time it took to the input of the patient, the number of people. So, and that just shows here in a slightly different format the duration. So the number of episodes. In the control group, it was 2.8, and it dropped to 2 by 12 months, and then 3.3 to 0.6, so quite a big effect. And the number of minutes of AF, they did a Holter monitor, so they put a tape on the patients, and they can look at how much AF they were getting. So it's reducing quite significantly. So, nice study. Now, we have to be careful with these studies, because it is only a single centre. Right? That means it was one hospital. The number of people is relatively small, so if it was like 500 there, we'd be happier. So it's a small study, but it kind of does what you'd expect, and it shows that there is great potential for patients to lose weight. Now there's all sorts of things. Somebody could say, but you haven't told us how many people had an ablation in each group whilst the trial was going on, and maybe that could have influenced things. Because say many more people in the intervention group had an AF ablation than in the control group, that could have a huge influence, couldn't it, on that? They were actually very matched between them. Some of them did have ablations in the two groups. So that's the first study, just simple paroxysmal AF. The other study, and this has been published in JACC, the Journal of the American College of Cardiology, again last year. And this is a slightly different study, because this is saying, okay, we can offer ablation to people, and sometimes we need to do more than one ablation. But if we were to target the patient with aggressive risk factor therapies, as well as doing the ablation, would it make our ablation better? Because we all know that ablation only really works first time about 50% of the time and 60%, and you often have to keep repeating it. This is akin to something else in cardiology, which is if somebody's got coronary artery disease, say they've got a narrowing in an artery, and you're going to put a stent in, you don't just go along and put a stent in and leave it at that. You make sure that their blood pressure's controlled, their cholesterol's controlled, you put them on aspirin, you treat their diabetes, you do all these other things. So why should AF be any different? Why should you just come along with AF and do an ablation and then leave everything else alone? Those things, blood pressure, obesity, were part of the causation of it. And if you don't treat those as well, the patient will be back. Years and years ago, in the 1970s, when they really started to do bypass surgery, the patients would come along and have a bypass. The cardiothoracic surgeon would say to them, it's all fine now, it's all fixed. Take them off all the tablets that they had. And then the patient would come back 10 years later with a problem. And then they thought, maybe, yeah, that's right. So we just put that bypass on. But actually, we didn't stop the disease process. We allowed it to continue. So then the penny dropped. You couldn't do that. And it's a bit like that, I think, in AF. We need to be thinking about these risk factors. These were the things that caused the AF in the first place. So we need to be attentive to those and not just keep ablating stuff. We need to ablate some patients, but we need to deal with the risk factors as well. So this is what this trial was done to answer the question. So, they had a lot of patients, 281 people, coming along for their first ablation. If your body mass index was more than 27, okay, that means so overweight, and you had one or more cardiac risk factors, so you had to have a high blood pressure, diabetes, previous coronary. Then you got your aggressive risk factor, you offered aggressive risk factor management, and I'll tell you what that was in a minute. Interestingly, of the 165, only 69 accepted the offer. You'll see why in a minute. 96 said, no thanks, I don't want that, I'll be the control group. Now, this is important. This is not a randomized study, is it? No. These people may be different from these people. Why? These people might be, I can't be bothered with that. No way. So they may be less motivated. These people may be highly motivated group. So now there's a potential. We've loaded up the intervention group with highly motivated people, and we've loaded up the control group with potentially unmotivated people. That could influence our results over time. Could be that these people will do better because they were like more adherent to their tablets and everything, and so did all the things they were asked. So we just need to be careful. This is a flaw in this study. They should really have taken these people and randomized them at that point to either standard therapy or the intervention. So it causes bias. So anyway, they didn't do that because if they'd done that, they'd only had 30 people in each group. It would have been difficult. So they've done this, and they've put people into these different groups. They had 61 people here in their intervention group and 88 in their control. So what did they do? They controlled the blood pressure really tightly. Patients had home blood pressure monitors. They had to do it 3 times a day. They had to have a target blood pressure of 130 over 80, 80% of the time. So quite aggressive blood pressure control. And if it wasn't at that level, they would give them more medicines for it. There was a weight management program, so like you saw in the previous trial, the lighter life type diet, they wanted to achieve a body mass index of less than 25, so keep people in the normal weight category. Exercise, lots of exercise, 20 minutes 3 times a week. They were on statins, diabetes control, sleep apnea was treated, so they intervened with that. If it was appropriate, with a CPAP machine, it's like a mask that helps the breathing. They were told to stop smoking and help to stop reduction of alcohol consumption. So this is trying to target every single aspect of that. This should be really fit people by the end of this. And the control group just got standard care. So what happened? This is really busy. Don't worry too much about it, but it does show you the effects of the intervention. So you can see here, this is the baseline weights of the controls and then a follow-up, and there's not much difference. But if you did this, these were slightly bigger people, 100 kilos down to 87 kilos. So they lost weight, BMI, body mass has come down. Look at the blood pressure, 160 to 120, phenomenal. But look at this, interesting. This group also improved a bit. Not as much, but they improved a bit. Diabetes, etc., the sleep apnea things improved. Antiarrhythmic drug use went down, which is good in this group. And other things like the frequency of AF dropped from 7 to 2, but it also decreased a bit in the control group. And other parameters for AF improved. So there was more effect in the intervention group, but there was also some benefit in the control group. So this is just graphical. It shows you the single procedure AF. So people who had an ablation, they went into the intensive group or the control group and followed up. And this shows you the number of people who were free of AF. So this is 720 days, so that's what, nearly 2 years. So if the control group here, you had about 30% free of AF at 2 years. Whereas in the intervention group, more like 70% free of AF at 2 years. Some of these people had a second ablation, and so they grouped the ones who had more than one ablation. And you can see again, the effects of ablation are that at 2 years you've got about half are free of AF, but in the risk factor management group, nearly 90%. So if we regarded this as a treatment, this package, it's better than having a second ablation almost. It really is very, very effective at keeping patients out of atrial fibrillation. So I put it to you that although there are issues with the way in which this study has been done, it's not randomized, it does seem to support strongly the idea that we should be targeting all of those risk factors and making sure that when we see a patient with atrial fibrillation, we are making sure the blood pressure is controlled, giving good advice about losing weight if the patient's overweight, making sure that whether they've got sleep apnea, if they have got it, treating it, making sure their diabetes is well controlled, telling them about alcohol reduction and stopping the smoking if they're smoking. If we're doing all those things really intensively, we won't probably see as much benefit as they did in this trial, because in the trial you will always see more benefit. But we'll be having a good effect on our patients to reduce the likelihood that they're going to either need a second ablation, or if they have a second ablation, that they're going to end up in atrial fibrillation again. So it's quite powerful, this. It needs to be repeated in a randomized study, but it's very powerful data. And it speaks to this idea that all those factors are what are promoting the AF, so if you want to reduce the burden of it, you need to do more than just cool or burn the atria. You need to do this risk factor management program, and that helped to reduce the incidence of AF. So we've got two nice studies that suggest if you really go for the risk factors, it does improve the outcomes for the patients. And I just put it to you that treating AF is more than just medicines and ablation. It is about trying to reduce the recurrence of this condition. And if we don't pick that up yet, and I don't think the majority of electrophysiologists have picked that up, they're so busy either giving tablets or ablating things, and if it doesn't work, more ablation and more ablation, that they've kind of lost sight of the fact of what's causing it. It's like going from room to room in a house, you know, putting a fire out in one room and then it's burning in another room and not bothering with that until the fire's coming under the door. Oh, then we'll put that one out. So unless you deal with the root of the problem, you're just going to have fires popping up all the time. I'm going to stop there, and I'm very happy to take any questions that you may have.